limb swelling since 4 to 5 days. Uh, Loose stools were initially 8 to 10 per day, watery in consistency, yellowish, non-mucoid, non-foul smelling, non-explosive, gradually increasing to 20 to 25 episodes per day, occasionally associated with small quantity blood mixed with stools, associated with generalized abdominal distension, usually present after meals and disappears after passing stool. Abdominal pain was dull aching, periumbilical, present throughout the day, non-radiating, not associated with food intake, no aggravating or relieving factors, no nocturnal awakening. Bilateral leg swelling since 4 to 5 days, insidious in onset, non-progressive, associated with decreased activity and reduced mobility, not associated with swelling anywhere else in the body, not associated with breathlessness, decreased urine output or frothy urine. Child has significant past history. Since 1.5 years of age, patient has been having persistent loose stools of similar character on and off, resolved after 2 to 3 weeks on oral medications, sometimes requiring hospitalization. Patient had relief for 6 months in between. At 2 years of age, repeat similar episodes of loose stools, increased frequency and larger quantity of watery stools not associated with blood in stools, with oil drops, associated with dull aching pain, associated with generalized swelling all over body, requiring prolonged hospitalization, associated with significant but undocumented weight loss and poor height gain as compared to peers. She was evaluated and underwent multiple blood and stool investigations and also endoscopic evaluation. Mother was then advised to avoid wheat,
तेही पार्टिसिपंट आहे बाबू, त्यातले आपण दोघी आहेत.
which she followed for 6 months. However, there was no relief. There is also a history of taking homeopathic medication for 6 to 8 months, but still there was no improvement. During this period, child had impaired growth, poor weight, and poor height gain. Patient was also given dietary restrictions, but no improvement was seen. There's also a history of hypopigmented patch over forehead since 5 to 6 months, initially pea-sized, now increased to involve left face and cheeks, not associated with redness, itching, scaling, or peeling of skin. No hypopigmentation anywhere else or of hair. There's no history of joint swelling, skin rashes, redness, or pain of eyes. No history of allergy or topi, asthma, or any family history of the same. No history of recurrent respiratory tract infections, hearing loss, skin infections, or ear discharge. No history of abdominal surgery. No history of COX or COX contact. No history of excessive intake of carbonated drinks. No history of blurring of vision, difficulty in night vision, no history of dry skin, scaling or peeling of skin or any neurological symptoms, no history of petechiae, ecchymosis or easy bruising. Antenatal history was uneventful. ANC was registered. Um, Birth-wise, child was born full-term, normal vaginal delivery, birth weight of 2.9 kgs, cried immediately after birth, no NICU stay. Child is immunized up to 18 months of age. Developmentally achieved all milestones at appropriate age. There's history of unable to walk since 2 to 3 months, but no fine motor or social or language milestones regression. Dietary history, child was exclusively breastfed till 6 months of age. Started weaning and complementary foods from seventh month with rice, dal paste, smashed fruits and vegetables. Eventually eating from family pot at 1 year of age. Started eating boiled eggs since last 6 to 8 months on doctor's advice. Child takes vegetarian diet, 6 meals per day, 5 out of 6 major food groups included. Calorie deficit of 380 kilocalories and protein deficit of 5 grams. Family history, there's no history of similar illness in the family. There's history of one sibling death, the cause of which is not known. Socioeconomic history belongs to lower socioeconomic class according to Kupuswamy scale of classification. Uh, Impression 4.5.
Go back, first line. Hello. So what are your thoughts on this history? 4-year, 8-month-old girl with loose motion since 2 months of age, or 2 months rather. So, correct, but presently since 2 months, what I mean, I want you to think on the present history of 2 months of loose stools and see what all you can get from that, which will take us backwards. My first question is, what kind of loose motions can last for 2 months? Chronic diarrheas are more commonly non-infective. That is the first thought that comes to your mind. Then what else? If they are non-infective, then what are they? Malabsorption. So then which fuels your next question, and what is that next question? So one is you'll ask for type of stools details. So steatorrhea is one of that. What else? So can malabsorption start suddenly at 4 years, 8 months of age? Can start. I'll tell me when can it start? So you have to ask, so again, that same one question which we always say, was this child absolutely all right 4 year, 8 months back? Was that a very acute episode which has never resolved? And then we get into why that happened. And here, obviously, you will get that this child was not all right, and there have been many such episodes in the past. Right? Okay. Now, for malabsorption, you said one you will ask for steatoria. What else will you ask? Basically, you have two questions in your mind. One is you want to know whether it is carbohydrate malabsorption, fat malabsorption, or protein malabsorption. If you can find out, that is one question in your mind. And what is the second question in your mind?
Primary word.
Very good. So is it primary or secondary? Means what? Primary means what and secondary means what?
Second, the infection that will be loss of the epithelial cells in the spinal fibula. So there will be enzyme deficiency, hence the malabsorption. Primary, some increased enzyme production.
So some genetic defect or something. Can you differentiate the two clinically? Primary and secondary? Okay, if you get an acute illness following that, what else?
Primary actually is present a little earlier.
What else?
Primary from the inability growth retardation. Secondary, relatively okay until the zone has started.
Okay, but if secondary lasts for a while, then the pattern will be the same, no? Systemic disease rate more affected than height, which is also the pattern of malnutrition. So it's difficult to differentiate. What is the other differentiation? Secondary is associated with inflammation. Primary is associated with inflammation. secondary to celiac disease, inflammatory bowel disease, whatever. So likely inflammation, so likely constitutional symptoms of chronic inflammation. So poor appetite, not very full, etc. Whereas primary malabsorption is always very eager to eat because there are no inflammatory issues.
I think there are two issues. Malabsorption is what all of you said. Now, whenever there's a malabsorption, the first history is, do you have a good appetite or a poor appetite? Okay. Why should malabsorption have a good appetite? Every disease has poor appetite. And can malabsorption have a good appetite? And then we kind of branch out to two different groups of malabsorption. So we will talk about good appetite in malabsorption. And the answer is non-inflammatory malabsorption. Where the inflammatory malabsorption has a loss of appetite. So that's a big difference. Okay, that's number one. The second thing is that after 2 months of such a symptom, we want to know how severe is the pain. Pain is inflammation. But even if it's a non-inflammatory malabsorption, there is always a gaseous distension, intestinal distension. So there could be some discomfort which patient complains of pain. But if it's an inflammation, then the pain may be moderate to severe. And I think therefore, how long does the pain remain? Is it occasional? Is it severe? All that might tell us whether there's an inflammation or no inflammation. Having discussed that we have inflammatory or non-inflammatory malabsorption, the next is you have edema, right? You discuss about that malabsorption. Okay. You also possibly discuss about carbohydrate malabsorption. And carbohydrate malabsorption is typically a lot of gaseous distension, passes a lot of gas, and there is always an local anal excoriation. Okay, so you get a history of carbohydrate malabsorption. But here the story says edema. Don't you think it's a protein malabsorption? You obviously hypoproteinemia in this time. Otherwise, this edema is not liver, kidney, etc. This is intestinal. So what is intestinal? It is definitely hypoproteinemia. Malabsorption with hypoproteinemia. Don't you think it's typically a protein malabsorption? So have you heard about protein malabsorption? What kind of protein malabsorption? I know carbohydrate malabsorption. I know fat malabsorption. Can you give me an example of protein malabsorption?
Come on.
Hmm.
Huh? Pancreatic enzyme deficiency. What else?
Protein allergy.
Cow milk protein allergy. Then
In other words, on one side, protein losing enteropathy. Okay, broad term. And that malabsorption includes maldigestion. So what is the difference between maldigestion and malabsorption? Many times parents come and say, digestion ठीक नहीं है. Now, if you ask them what do you mean by that, they say they're loose stools. Is loose stools a digestion problem? Or is it an absorption problem? Or is it an excessive intestinal secretion problem? So what is maldigestion? We call it indigestion. Okay, but like malabsorption, you have maldigestion. So what is digestion and what is absorption?
you
Both are
said
same.
pancreatic enzyme. So what is that?
So what is the difference between the two? Okay, in both you have loose stools. Both you are losing energy, both you are losing whatever is being lost. Then what is the difference?
and they're not broken down. So there could be a lot of osmotic diarrhea because of water involved. Another option would be small spoons. Maybe in fact, depending on what kind of movement and fat would be small but bulky spoons.
Now, like food, when you study, it's an intake of information. It is intake of food. Okay. So has the study to be digested and then absorbed? So what do you give? How do you look at these two terms? Whatever we are teaching each other, we need to digest it first and then absorb and then retain and then use. So much of process to go before I can answer your query. So what is digestion and what is absorption? So digestion is breaking down the main molecule. So whatever you are learning, you want to break down into small parts which only can be absorbed. So you read the whole lesson, you will have to digest it before you absorb, which means understand what's happening. So when the whole protein is taken by whole food or whole carbohydrate or fat, it is to be broken down into small molecules like amino acids. And only when proteins are first broken down, that is digestion. And can protein not be absorbed? Suppose I teach you something, you don't digest, which means you don't understand. But you still absorb it. We passed all that, but only rotate learning. If you ask me what does it mean, I say that I don't know, but I got a gold medal. Okay. So do you need to digest or you can straight away absorb? The knowledge you can do that, right? Without knowing what it means, you can blurt out the right answer and you get the good marks for it. So can you absorb without digestion? No. But information, study you can absorb. No? So the point is that if proteins are not broken down, proteins are also absorbed. Okay, it's not that they are absorbed, not absorbed, but that's a foreign protein, so it causes an allergic reaction. Okay, and the same thing happens with the study. If you don't digest, you absorb, but it cannot be retained because it is not in the form of retention, and therefore it's lost. So digestion is first important, then absorption, and of course, because you absorb, you may not retain, and because you retain, you may not be able to use it. So that's a different process, and therefore, I think we need to really look at that when this is protein losing. So do you think this protein is not digested at all or not absorbed? Because there is an edema. And if something is not digested, it's not absorbed. For absorption, you need a digestion. But even without digestion, protein can get in. Okay. In other words, this process of digestion seems to be reasonably okay. There could be an overlap between digestion and absorption, but the real problem looks to be absorption. And to that extent, we will have to look at whether it's non-inflammatory or inflammatory. And if it's inflammatory, then inflammatory bowel disease is celiac inflammatory or non-inflammatory? Non-inflammatory. Is cow's milk protein allergy inflammatory or non-inflammatory? Nobody's allergy, right? It's inflammatory. Celiac is also inflammatory, right? So the common small intestinal protein in maldigestion and malabsorption are likely to be inflammatory, whereas the carbohydrates and fats may be also non-inflammatory because specific enzyme may be lacking. And therefore lactose intolerance is non-inflammatory. Okay. So I think we'll keep all that in This is the basics with which we start thinking on this channel, right? Now, having said this, do you think this is the first time? Can you guess whether this is the first time or nth time? On the history, ask her some questions, which she might have put up here, or she might have put up in the next slide. We have not seen that slide as yet to discuss. So what questions would you ask to guess only on this slide whether this is the first time a child is having this problem or this is whole problem with new recurrence?
How has he been prior to the chief thrust?
So how was he just before the onset of this?
And in other words, you need to know whether he is gaining weight, height, etc. But parents don't know gaining weight, height. I said, कभी लेजर नहीं किया किसी ने. Now what question they ask? And therefore, activity, energy, happiness, sleep, everything. But if you are not doing well, everything is getting upset in your routine. Okay. For example, if I don't want to go to college, I give some reason, but then I go with my friends, I go for a movie, I go to a restaurant. So my health is all right, but still I don't attend, saying that I'm not well. So if, as a teacher, you come and say I was not well, I will ask you many questions to find out whether you are really well or not. So ask all these questions, right? And that might tell you where you are. Yeah.
So now this description tells you what? 8 to 10 watery, yellow, non-mucor, non-foul smelling, non-explosive, increasing to 20 to 25 per day. Where is the anatomy? Small bowel or large bowel or both? Why you said small bowel?
More watery consistency and the frequency of loose fluid, the amount of loose fluids.
Yeah. So between small bowel and large bowel, whose stools are bigger in volume?
Large volume.
So that depends on the type of problem. So there's hardly any pathology of the large bowel where water will not be absorbed. Water absorption in large bowel happens almost always. So, and what happens in the small bowel with respect to water? What happens?
After all, water is absorbed by the large intestine. Okay. When your large intestine is all right in a small intestinal disease, why should there be water in stool? Large intestines are working well. But you said that watery stools, frequent small watery stool,
secretes
small
water.
intestine.
And the
Then why is that?
magnitude of secretion is huge. In an adult, it is 8 to 10 liters a day. Okay, so that is why small bowel stools are watery, large quantity rather. So between when you come to quantity, small bowel stools are larger in quantity than large bowel stools, right?
Would this suggest, so this could be both, small and large. So that is one thing we have learned. That this is possibly both. Okay. Can you suggest me the pathology on this slide? What kind of pathology? Inflammatory or non-inflammatory? Excellent. There is some blood, no? It has to be inflammatory. So you got an inflammatory, small and large intestinal anatomy. Okay. So,
And what does that distension mean? Distension present after meals and disappears after passing stool. So could be gaseous distension, which means which malabsorption is there? Carbohydrate.
so you have a carbohydrate and also protein. Okay, so it's not an enzyme deficiency. It's not non-inflammation. Okay. And further down, she has put up some oil drops. So fat also. So everything is absorbed. Don't you want to know whether vitamins and minerals are also not absorbed? Or it's only protein, carbohydrate, fat?
So how will you know?
Normally, we never consider all that, right? But you can have a copper problem coming up, and then you start wondering whether it is maybe Wilson's or Wilson's life. Okay.
So abdominal pain, what do you interpret from this? Which organ? Small intestine. So abdominal pain, mostly small intestine. So again, inflammatory is added. Then bilateral leg swelling. So what do you make out of that interpretation? So hypoproteinemia. Now, whether because of long-standing nutrition is affected or whatever, so hypoproteinemia.
But is the liver also not involved in digestion? Okay. Many parents feel the liver therefore there are digestion issues. They don't consider intestine, they consider liver. So is liver concerned with indigestion? Digestive process?
Yeah, it will contribute to fat malabsorption
Okay.
and maldigestion because if there's no bile, then fat can't be
Because of the bile.
emulsified. So
Okay, fat nerve. But now in between is all right. So this must be infection. How can it be all right in between for 6 months? So can you treat such inflammatory intestinal disease, which is so symptomatic for a long time? So it must be infection only. Treated, but when 6 months he was all right, he came again. Unhygienic situation, bottle fed baby, socioeconomic group 4, hygiene is poor, classical story.
And unlikely to have such a long duration of. And it be only infective
That's
origin.
a chance, no? I mean, I eat every day roadside, bhel puri, whatever, but I get diarrhea only once. And I said, sir, इतने रोज से तो खाता है, कुछ नहीं हुआ.
So can non-infective inflammatory have breaks in between is the question. Why?
Causes sometimes like IBD also.
So there are exacerbations and remissions of most chronic diseases.
In fact, the allergy or the immune mediated classical is sudden appearance, sudden disappearance, recurrent, okay, up and down. That is classical. If I get urticaria, by the time I go to my doctor, it has disappeared already. And the doctor says, I can't see anything. So go back. And when I reach, it comes again. So off and on. Okay, so that's typical. So looks like what we are discussing. But there is a hypopigmentation, which means the B12 is not getting it. You got another malabsorption? Okay.
Agreed?
It leads to hyperpigmentation.
Not one fat somewhere. Okay.
So what is this now?
So now the skin is also involved and the intestines are also involved. Classical zinc is not absent. Zinc is skin and intestine. Acrodermatitis, okay. So zinc deficiency.
Or any other thoughts? You have any other thoughts? Very good. So if it is autoimmune, then it can
So
affect.
it's another immune disease. Excellent. Okay, so we'll leave it at that, right? I was coming in between. You give me a very subtle, please sit down. I'm coming.
Okay, so now come and tell us your summary and then examination.
Is cow's milk also given?
Uh,
Just cow's milk was also given. Yeah, so cow's milk protein allergy.
yeah.
4.5 years old female child presented with prolonged history of loose stools with weight loss, pallor, with impaired growth, acute on chronic malnutrition, with dietary and caloric and protein deficit. Is a case of chronic diarrhea involving both small and large bowel, inflammatory in nature, osmotic more than secretory in nature. Differential diagnosis, inflammatory bowel disease, abdominal tuberculosis, multiple food protein allergies, celiac disease.
So we very confidently said non-infective influenza.
No.
But she has got abdominal tuberculosis, right? Yeah. Okay, chronic, inflammatory. So we only discuss non-infective inflammation, very confidently. But she has been very wise. She has also put infective inflammation. You agree to that? So give a thought, give a thought.
Why? You're right, but why? So pathologically, where is abdominal TB? First of all, abdominal TB means which TB? Peritoneal TB, lymph node TB,
So here intestinal TBCB, right?
the intestinal.
So where is the microanatomy? Which part of the intestine, not small or large?
Submucosa.
So tuberculosis is a submucosal intestinal disease. And this is outright a mucosal intestinal disease. Okay. So do you mean the intestinal TB has never diarrhea, but Nelson says alternating diarrhea and constipation. So it's a mucosal. I agree with you. Only because you have read so much, I have not read recently. You must be right. Why don't you say yes, you are right? Okay. You are likely to be right by saying she is right. So now tell me that, but there is a diarrhea and constipation alternating. That's what the book says. First thing is funny. How can diarrhea and constipation be together in the same disease? It's like a cough syrup having cough sedative and cough expectoration. I said, does it know which part it should use and which part it should ignore? So what's your answer to that? Give a thought. I think you are thinking, and you are thinking right. Okay.
So between the two, according to you, which should come first? Diarrhea or constipation? In that alternating diarrhea and constipation.
So suppose it's diarrhea, then it's a mucosal, no? So it must be first constipation. So my next question is, does constipation cause diarrhea? Funny. How can constipation cause those two? So retained stools could be even oozing from a side, whatever has been watery stool still not absorbed. But even besides that, there is a retention, and the retention might mean some infection, and therefore even a stool disease may have a diarrhea, and the habitual constipation often child leaks stools and soils the underwear. Okay. So parents come to you saying, बार soil होता है. So it's a loose stool, but you ask details, is constipated. And that is what happened. But in that case, constipation is the chief complaint, and loose stools occasional, and in intestinal TB, that is what happens. Constipation mostly, but occasional loose stool. So the book says alternate. Alternate is not 2 hours this and 2 hours that, or one day this and one day that. No, that's not alternate. And therefore, it's unlikely. Okay, in medicine, you always keep that. Okay, because you cannot bet that your analysis is 100% right. But logic demands it's not intestinal. Again, any strong point again keep being intestinal. First episode at 1.5 years. Second at 2 years. Oh, this TB is waiting for us to understand its TB. So out of question. Okay. Then my question to you is, can a child not have two diseases one after another? Okay, there's a gap, no? I had a staphylococcal pneumonia. Thereafter, I got tuberculosis pneumonia. Possible. So do you think we have what? But we have ruled out because of our pathogenesis. And there's no reason why you are so unlucky to have two similar looking different diseases coming to you. Right?
Tell us examination.
And what is this multiple food protein allergy? I know you are second yes, so I also want you to start participating. What is multiple? So is multiple refers to food or multiple refers to food protein? So it doesn't matter. I'm just making you think. It means nothing. What she has said is right. But I said multiple food protein. I started wondering whether is food multiple or food protein is multiple.
Food protein. Food protein.
So what is multiple food protein? I know in a kidney, there are different types of proteins lost in the nephrotic syndrome, small molecular albumin, large molecular globulin. So if you have got a minimal lesion, you are losing only albumin. If you have some other more involved disease, then you are having multiple proteins.
So what
So
did
what do
you
mean by
mean?
multiple protein? Albumin, globulin, alpha 1, alpha
Means
2.
give us examples. Give us whatever you can say. What do you mean by multiple food protein? Gluten. It is gluten exactly.
Carbohydrates, I know many. Okay, mono, family. That I know. Okay, that also I know. Some of them are the essential, non-essential. Proteins also essential, non-essential. Okay, so largely you might mean vegetable protein or animal protein. Okay, not important, but this is just because you have put it. Okay. Okay. So accurate, brief, and seize for clear, non-ambiguous. Okay, we can't say occasional crepitations. Person like me always asks what is the occasion. Okay, birthday or what? So no occasion, clear, right? So we just want you to think because I'm sure that you put it with some idea. Okay. Now, when I ask you whether you are able to convey to it, you are still junior. Okay. I'm sure they're also junior compared to us, so it's not that. But as they come near our level, in the next 1 year or next 6 months, she will be like us. Okay. So, yeah, ask all these, but you are right. Fine. Good. So, would anybody say, would the physical examination ever differentiate any of these? If not, then physical examination is useless admission. And I may tell the parent that I'm not going to examine because the examination will not show me anything. If not, you tell me what do you expect in this. You palpate some information.
Come on, something to will get.
No, this is just to think. Nobody wants you not to examine. But it's a good idea to anticipate.
Manifestations with it. There are autoimmune pathology that yes, there will be extra intestinal manifestations.
So look for extra intestinal manifestations.
Very good. Immune, she said about pigment, immune disorder. Okay, so that could be there. And you will know the degree of malfunction. How small is the child? How weight is affected, height is affected, milestones. Okay, but there is already a neurological problem in this. Because you said that he does not stand, right? No. The multi-system. What immune disorder the brain must have? She wrote in one of her slides, cannot stand or something, you know. I don't recall what you said, but yes, unable to walk. Unable to walk, what? Cerebellum, okay, upper motor, lower motor neuron lesion, blindness, unable to walk, and autoimmune. So now connect neurology with this multi antibody syndrome.
What are the possible reasons why this child can't walk now since the last 2-3 months?
Can intestinal problem which we are discussing make him not walk?
So one is weakness, then
He has edema.
edema.
But weakness and edema, nephrotic with massive edema running. So edema is not the cause. And weakness to what extent? Weakness not able to walk is extreme weakness. Maybe, we are not sure, but that is not a common
What
symptom
else?
of.
Can you link it to something nutritional? B12 and vitamin D.
Not necessarily in this side, but the part of PEM and multivitamin deficiency, it could be vitamin D, B12, etc. And therefore, we may look on clinical examination every part of deficiency. Okay. So that is important for what we should have an exam. So in an examination, you would make a mention that there are no signs of vitamin deficiency, mineral deficiency, which means you have thought that there could be some.
On examination, the child was febrile, alert, and conscious, heart rate of 110 per minute, RR of 20 per minute, peripheral pulses were well felt, saturation was maintained at 98%, BP at 50th centile, severe pallor was present, grade 1 clubbing present. Is 49, 02 -1 standard deviations, and weight for height less than -3 standard deviation. Impression severe acute on chronic malnutrition. Uh, on head to toe examination, skull hair normal, eyes normal, no signs of vitamin A deficiency, hypopigmented patch present over face, irregular involving left side of face and cheeks, angular stomatitis present, skin and nails normal, Harrison sulcus present, spine and genitalia are normal, and healed perianal excoriation present. On systemic examination, per abdo examination, abdo is scaphoid, non-distended, skin normal, no scars or sinuses, umbilicus normal, palpation soft, no tenderness, guarding or rigidity, liver 3 centimeter below subcostal margin, firm with sharp borders, smooth surface, extended to epigastrium with left lobe around 2 centimeters, no spleen palpable, no other mass palpable. On percussion, no ascites, liver span of around 7 centimeters. On auscultation, bowel sounds heard. Systemic examine CVS S1 S2 heard. RS air entry bilaterally equal. Clear. CNS tone normal. Power more than 3/5 in all 4 limbs, and reflexes 2+.
Just go back to 3, 4 slides, go back, stay put, next slide. Next slide, next slide. Next slide. Yeah, stay there. Addition surface. Severe liquid. And no other signs of liquid. No artificial enlargement, no bone, no blood, no undergraduate also. Only Harrison surface. You see the only Harrison surface in vitamin D deficiency.
So which sign of rickets comes at what age? So when will Harrison circus come up? What age? In
That's what is recognition and enlargement of the wrist comes.
It starts to bear weight on its
Only when it starts putting the. Okay. So Harrison circuit is at the costochondral junction. When are the costochondral junction working more? That's the time Harrison circuits will come. Hmm?
2 to 3 years, decades, lifespans. So infancy, no, early infancy.
The respiratory rate is more, no? Okay. So would it remain forever? Because now it's not infant. It should have disappeared, no? So do signs of
One, it depends on activity of the ricket. So is the rickets active or not? Or it has died down? That was a period of rapid growth, then growth has slowed down or some more vitamin D has come in. There are some things known as atrophied rickets or old rickets. So some deformities are left behind. Now frontal bossing, if it remains for a long time, that head will look bossed even later. So that is an old sign. It is not rickets at 4 and 5 years old. Right?
is Harrison circus seen in children without vitamin D deficiency?
congenital
Cachexia के पहले का दूसरा important reason भी होगा.
congenital heart disease.
Very good. Congenital heart disease.
Okay. So just keep that in mind. So in a congenital heart disease, you might see Harrison circle, and you make examiner hear that properly. Then he will ask, "Oh, you mean vitamin D deficiency?" No, sir, there are no other signs. Then why is that so? So why is congenital heart having Harrison circles?
So chronic increased respiratory rate.
Right?
Chronic
This is
respiratory.
just to bring to your notice, because moment you say Harrison, so the examination, if you saw Harrison circles, don't mention it. He is unlikely to ask. And if you say, what about chair? So, sorry, I forgot to mention there is a Harrison circus. Then you are in it. But why tell him to ask some funny question, right? The next line. Now here, scaphoid abdomen, there must be diaphragmatic hernia. I know only one cause of scaphoid abdomen, and that is diaphragmatic hernia. Maybe coincidental, but I must look at it carefully on my investigation. Your comments? You agree to my first statement? Scaphoid abdomen is diaphragmatic hernia. Okay. This must be diaphragmatic hernia. I'm not seeing scaphoid abdomen anywhere else.
Yes. Activity affects what I without predominantly any other respiratory components.
So scaphoid means what? Interpretation. Why is it scaphoid?
Malnutrition.
Malnutrition. So one reason could be that all the visceral masses are less. Secondly, it depends on what position you examine the abdomen. So in a undernourished child, if the child is totally flat, you may have that, but you can also have distension. Why do you have distension? We'll talk about it just a second. Gaseous distension, poor muscle tone and all that, right?
So abdominal distension is seen only on lying down. And if the abdomen is protruding beyond the chest, it's called abdominal distension. Otherwise, all Indians have an abdominal distension for no reason. Then you know we are called thin fat Indian. That means thin people also have a protruding abdomen, and fat of course have it. We are called thin fat Indian. That's our gene. Okay. But when you lie down, the chest is higher than the abdomen. That means you are not pathological abdomen. Just to bring out the point. Okay, you saw it, so you have put it down, right? Okay. But you will be caught only because you are very good in your physical finding. And you must know what to hide to an examiner as well. Okay.
We'll get the baby.
No, sir, she's not come.
With that baby is the second child.
Second child.
Fine, tell us.
4 point impression 4.5 years old female child presented with chronic diarrhea with pallor with hepatomegaly, impaired growth, skin hypopigmentation, pedal edema, and signs of micronutrient deficiency with acute on chronic malnutrition is probably a case of inflammatory bowel disease, Crohn's disease versus ulcerative colitis, multiple fruit protein allergy, or immunodeficiency disorder.
Any comments on immunodeficiency? On one hand, you are telling me immunoinflammatory disorder. On the other hand, you are also putting immunodeficiency. One is excess of reaction, another is lack of reaction. Do you think both are possible? And your answer is, now that you say that it's an immunological disorder, then immunological disorders could have in the same patient multiple types of disorder and immune deficiency. For example, an HIV is an immune deficiency, and you can have a Burkitt's lymphoma, a malignancy in the same patient. Okay, so just similar question: Can a cerebral palsy have hypotonia, spasticity, and also the twisting dystonia all in one? Because in an examination, where you tell examiner that there is a spasticity, I'm going to show you hypotonia. And catch you there, where is hypotonia? Then you will say no, both. And there will be both. One is upper motor, there is another lower motor.
Have you seen it in any CP patient, simultaneous spasticity and hypotonia?
But we have seen dystonia and spasticity in one. It's been two different anatomies. One is basal ganglia and another is pyramidal tract. In the same patient. When you have in the same patient a lower motor neuron.
No, not malnourished. The reason is different. Why do you get dystonia and spasticity in the same patient?
Because the brain disease is distal in nature. Pyramidal tract and also basal ganglia. Few progressive neurological disorders can also have peripheral neuron. Okay, like a typical MND may have a peripheral neuropathy, but that's not common. So your answer is non-neurological hypotonia.
That's malnutrition, which you said.
Okay.
And in some severe cases, the cortico, the lower down fibers, corticothalamic, corticohypothalamic, they are all broken at different areas. That leads to hypotonia. So therefore, you'll have a mixture because extensive involvement anatomically, you can get hypotonia.
Why does Downs have hypotonia? So disseminated pathological waste. Okay, that's what you were talking about.
Investigations on presentation, the child had HB of 6.3 with hematocrit of 27.4, total leukocyte count of 15.9 K, platelet count of 1086 K, electrolytes were deranged 127, sodium 2.9, potassium 1, creat 3.5, SGOT PT within normal range. Total protein albumin, total protein was 4.9, albumin 2.2. Stool RM was sent, which was suggestive of pus cells 2 to 22-25 per high bar field, and occult blood was positive. ESR was sent, which was ESR CRP both were raised, 22 and 27.4, fecal calprotectin 450. IgA levels were raised, serum TTG IgA and serum TTG total were within normal limits. Cox workup was done, which was negative. CT abdo was done, which was suggestive of smooth long segment circumferentially, mildly enhancing wall thickening involving ascending, transverse, descending. Sigmoid, colon, rectum and anal canal, recto-sigmoid junction, distal jejunal loop, ileum, including the IC junction, appendix, 3.2 centimeter in length, caliber 5.5, maximum thickness measuring 5 mm with maintained gut signature in colon and terminal ileum. Loss of colonic hostrations with creeping of fat noted along descending and sigmoid colon, mild surrounding adjacent fat stranding with prominent vasa on chronic inflammatory changes, advise scopy and histopathological correlation. Uh, Colonoscopy and OGD scopy was done. OGD scopy was suggestive of mild antral erythema and in duodenum scalloping on few folds, mucosa normal, no nodularity. Colonoscopy findings, ileum was normal, IC valve normal, wide open. A colon pancolitis seen involving more involving left side of colon, multiple abscess ulcers seen throughout, and deep ulcers seen on the transverse colon, descending colon, sigmoid colon. Right side colon shows generalized erythema. Biopsy has been taken from ileum and colon, and the report is awaited. The pic of ulcers present. We have also sent a genetic and immunodeficiency workup, but that is awaited. And
It shows the protein measurement. Yeah. There's a reversal of underlying globulin ratio. 2.7 globulin and 2.2 albumin. And the imaging shows liver enlarged, hepatomegaly. So liver is also involved in this. Classical story of a reversal of underlying globulin ratio is a chronic liver disease. Okay. Is nephrotic also reversing? Because globulin is 1 gram. Total protein is certainly not 2 grams or 3 grams, 4 grams. So globulins are increased. So reversal occurs in nephrotic also. But when we talk about liver, we say reversal of unbearable liver. This one reversal. Okay. And you have a hepatomegaly. So there is a liver disease also. I should do a liver biopsy.
In nephrotics, the albumin loss is more as compared to globulin. So it is not exactly reversing. It is the more loss of albumin as compared to globulin. Also, the change in ratio is what is important.
So what is important is that you should look at reversal when your total is normal. Your total only is low, then there's no point in looking at reversal. One of the two has to contribute to the low total. And whichever is low will reverse the ratio. So that is irrelevant.
And often in cirrhosis or nephrotic, the globulins are increased.
That's why total is normal.
So
Albumin is
albumin
low.
is gone down and globulins are increased. Globulins are increased in any antibody producing disorder. Okay. Whereas here it is not. 2.7 globulin is a normal globulin. And here globulins are normal, but albumin is low. Therefore, this is typically a malnutrition globulin. Right? And exhibit is normal.
Okay.
Good. Good job done. The insulin is only 5. Your chronic inflammatory disorder, inflammatory bowel, the insulin is only 5. Have you seen ESR 5? They say pertussis ESR is good. God knows why, who said that. Forget that. There is nothing of that. But this ESR is certainly normal. So you mean normal ESR is possible in an inflammatory bowel?
So what is your answer? Is USR always raised in all systemic inflammation?
And he must be anemic also. So anemia increases ESR.
And what
Inflammation increases ESR. With 2 factors, your ESR is normal.
what decreases USR?
In the cancer rate, ESR is increased depending on the severity of inflammation. This is only at the height of acute inflammation. In chronic inflammation, ESR will not increase. Okay, and therefore, in a chronic inflammatory disorder, ESR is at no tension. It may be 10, 20, 30, or it may be 5 or normal. But in an acute inflammation, yes, ESR will increase. Okay.
You have to first download the thing, then it will share. No?
Izan, a 1-year-old male child, third by birth order, born out of non-consanguineous marriage, hailing from Bihar and residing in Titwala, Muslim by religion and Sheikh by community, is brought by mother, who is the informant and reliability is good. The kid was brought with the complaints of abdominal distension noticed by mother since last 3 months. History of presenting illness. The child was apparently normal until 3 months ago, after which the mother noticed generalized distension of the abdomen, which is insidious in onset and gradually increasing in size. Mother initially thought it might be because of gas accumulation and did not seek any medical attention for it. And 5 days back, while massaging the kid's abdomen with oil, mother noticed there is a single large swelling in the left side of abdomen, and that is history of for since past few days, there is history of increased irritability, lethargy, and poor feeding in the
I think we'll stop at this. Okay. Sit down. Let's discuss the possible, you can, stay there. Give a possible diagnosis. This is given enough. Okay. Whatever little here and there, we will fine tune it. But come on, come on.
1-year-old accidentally noticed lump in the left half of abdomen. So what is it? Spleen.
Left hypochondrium is the tail of the pancreas. Left hypochondrium is the colon, a transverse and descending colon. Okay. How are you so sure it's spleen? There are other structures there. And there is a left lobe of liver also on the left side. No?
So any logic in calling it spleen? Logic is right, but what is the logic? Pancreas is superficial structure, deep structure. Retroperitoneum.
So it will never come like that. An isolated left lobe also comes in the epigastrium. Okay. Colon again, colon itself is a large organ. In that, but any tumor is not easily palatable. So that comes as a lump in the left hypochondrium is always in. So you have a 9-month-old who started developing apparently a splenomegaly and has no other complaint.
So diagnosis, thalassemia. Storage disorders. So take one by one. Thalassemia, yes or no? Can be a possibility. So think of reasons why it cannot be a possibility.
Starts at 9 months old. It can start at any time.
Hepatosplenomegaly, so not just lung but abdominal distension.
But just tell me that don't whether it's noticed this lump, how old this lump must be? History suggests 3 months. Will it be 6 months, 9 months? 3 months definite. So we know that this is a long-standing splenomegaly. We want to know whether it is even beyond that. Okay. Now, lump is palpable easily over 3 months. It started at 3 months, abdominal distension. So at 3 months, there was a sizable splenomegaly, and the spleen becomes just palpable when it is 3 times large. This must have been palpable at that time, maybe 4 or 5 times large. So that means it started even before 3 months ago. Okay. And maybe somewhere 6 months or even earlier than that. So we know the onset. Okay. Now keeping that onset, could it be a storage? Could it be
PDF change हो गया है।
Or could it be focal appetite?
नहीं आ रही है दूसरा
Could it be chronic malaria?
वो नहीं था
Could it be chronic mild
वो
leukemia?
केस है था लेकिन
So few common
फाइन ट्यून्ड
factors.
पीरियड
Okay.
लास्ट फाइन
How would you separate them out just by that much? Could it be chronic malaria?
some history of fever in the past.
So now this is not malaria. Kala alert. Again same thing. Okay. So malaria, kala infections are out. All infections are out. Okay, hypertension.
No.
Leading manifestation will happen later. What can come and go. Not necessarily come and go. What was the age? When have you seen extrahepatic focal hypertension coming at what age? 4, 5 years, 3, 4 years.
Not what pre-sinus are, only spleen, no liver. Is that possible? And the cause is obviously some congenital problem. Somewhere obstruction to the portal venous system, which is since birth. So would you consider a portal hypertension at that stage? It's likely to come with a large spleen so early in life. But we keep it at the back of our mind. Just because of that, we can't throw it out. But malaria causas are out. Focal hypertension, we keep it below that. So it is neither of that. Chronic myeloid leukemia, typical splenomegaly, only fine, no other complaints. You're not very pale either.
They'll ask for other symptoms, easy visibility, other constitutional symptoms. Are there any other cell lines involved at the time in symptoms?
So your reason is CML is rare type of leukemia and further rare at that age. That 9 months of age starting. So possibly not CML, possibly not pre-sinusoidal focal hypertension, not malaria kala azar. So common things are all out. So must be hemolytic anemia. Okay, as a common thing, there could be a cyst in the spleen, that we will not know. But commonly, so it's an hemolytic anemia. What kind of hemolytic anemia? Spherocytosis, sickle cell, combination of abnormal hemoglobins, or classical thalassemia lesion.
Take one by one and say points for our audience. Thalassemia, we just said that one is should be hepatosplenomegaly, should come as abdominal distension with progressive pallor. As Sir said, this seems to have started very early. So those are the few points which make thalassemia less well.
The thing is that the liver enlargement may not come out well in the history. When the liver is only enlarged, abdominal distension, upper abdominal is classical. But when spleen is so much enlarged, the attention is only on that side and some, anyway, the splenomegaly in hemolytic anemia, hepatomegaly in hemolytic anemia is not massive.
So we can't rule it out. Okay, then what about HS? So jaundice is mild, they may not have noticed family history, so we'll ask for that.
What family history? Thalassemia is also family history. Sickle also is family history. Everything is family. You know? What is so great about spherocytosis? It's an autosomal dominant. So how do you know in the history that it's an autosomal dominant? Without examining the parent.
Short parent.
Okay, one of the parents must be short. And he may also have mild jaundice. Okay, so spherocytosis can be picked up with that. The large spleen is unusual. Okay, by the time the large spleen is a little old child or even almost an adult. Okay, sickle.
So should have presented with some crisis.
But you can't wait for a crisis to come, right? You only hear always, crisis will come. So what's your comment on a large thing in sickle?
Yeah, in infancy it is possible.
Okay, and even no crisis is also possible, but surely just the large plane coming as a lump in abdomen looks unusual. Okay, now, so this is the way. Now, would clinical examination differentiate between?
Sir, he also said storage.
Storage, yes, I forgot to do that. What about storage? Infantile conscious, living things?
Ask about developmental history.
So developmental history you will ask, but whether it has to be affected or it may not be affected.
Typically, living takes in an infant takes multi-system, classically neurological presentation. But a cautious could be just only spleen. Okay, so we keep that in mind. So you have a storage, either monolithic anemia or that, right? Let's see what she has to show us.
The child was
She has
normal.
increasing paleness. The storage ruled out. So would you bet that this is not storage or would you bet there is storage? So the point is that infantile portions, for example, by the time even bone marrow is involved, there is some time lapse. This has happened too early in the course. So we'll keep it at that mind, but possibly not. Okay.
The child was normal 3 months back, after which the mother noticed generalized abdominal distension, which is insidious in onset and gradually progressed to attain the present size. There is no history of fever, vomiting, abdominal pain, or constipation, and the mother didn't seek any medical attention for this complaint. Currently, since last 5 days, mother has noticed a swelling in the left side of child's abdomen while massaging with oil, which is large and firm
What
in
does that
consistency.
mean? Easy bruisability and greenish discoloration. We did not expect all that. No? So we are going astray somewhere in our discussion. What is this? The easy bruisability. It's certainly bleeding, right? So is it fragile blood vessels? So vascular problem? Is it platelet problem? Or is it a coagulation problem?
Platelet.
Platelet. Okay, why not coagulation? Also bruisability. And then greenish by liver disease. And liver disease with liver photohypertension, chronic liver disease.
Greenish is just the change in color of the subcutaneous.
So the bruise changes color, so greenish. And why not coagulation?
Deep seated leads to the.
And so is the platelet down, it must be leukemia, no? So mycytopenia same state. Severe anemia with thrombocytopenia, leukemia till 2011. Plastic anemia, because spleen is involved.
So usually in hyperspinism, you just get a investigational thrombocytopenia.
Not clinical bleeding. It's a clinical investigatory finding, but not clinical finding. Okay, so we take a note of that, something unusual that we are not ready to do. So could it mean that this is a sickle really, which has gone into aplastic crisis? Anemia has become severe, platelets have gone down. Okay. So is that a possibility?
So plastic crisis is a sudden event, acute event.
So this is not crisis, there is nothing crisis. Okay. See, failure in examination is not a crisis. It is happening slowly, but the exam is still far away, no? So the result is later, result is acute. But it's not a whole true process. So this is not one of those.
No history of high-grade fever with chills. No history of yellowish discoloration of eyes, bloodstain vomiting, or passing black tarry stools. No history of periorbital puffiness. And there is no history of cyanosis or cycle or recurrent respiratory tract infections. No history of floppiness or seizures or regression of milestones, or no history of visual or hearing defect, no history of poor weight gain, no history suggestion of pica or passing worms or blood in stools, no history of refusal of feeds or easy fatigability, no history of breathlessness or swelling of hands and feet or reduced urine output, no history of recurrent infections or bleeding from injection prick sites, no history of previous blood transfusion, no history of any similar illness in family members, and there is no history of any hospitalization in the past. Past history is not significant. Antenatal history is spontaneous, uneventful. Birth history, it's full term. Born by LSCS, indication is prolonged second stage of labor. The child cried immediately after birth. Birth weight was 2.5 kg. There is no history of neonatal jaundice or neonatal seizures, and there is no history of NICU stay. But there is history of blood transfusion present in the mother during the postnatal period in the last two deliveries. Developmental history, gross motor, neck holding attained at 3 months, rolling over at 5 months, sits with support at 7 months of age, crawling started at 8th month, stands with support at 10th month, and couldn't stand without support and walk. Even the child is 12 months of age now. Rest all the domains milestones are appropriate for age. Isolated gross motor delay is present. Diet history. The child was on exclusive breastfeeding since till 6 months of age, and there is poor complementary feed introduction present. And the current expected calorie intake is 760 calories, but the actual calorie intake is around 550 kilocalories with a deficit of 225 kilocalories, and there is no protein deficit. Immunization history, only birth vaccines have been given. Socioeconomic history belongs to lower socioeconomic status. According to modified Kuppuswamy scale, there is no history of recurrent blood transfusions in the family members, and there is no history of gallstones in the family members. Summary, a 1-year-old male child brought with complaints of chronic, gradually progressive, generalized abdominal distension and palpable mass in the left side of the abdomen with history of increased paleness and easy skin bruisability is a case of anemia with organomegaly, probably splenohepatomegaly under evaluation. To rule out, my first DD is hemolytic disorders causing extramedullary hematopoiesis. Second is bone marrow infiltrative disorders. Third, storage disorder. Fourth, I'm keeping infective etiology, Cox or malaria. General examination. The child was alert, active, interested in surroundings, appears undernourished. Temperature is afebrile, heart rate is 110 beats per minute, respiratory rate 32 per minute, peripheral pulses are well felt, saturation 99% under room air, extremities are warm, pallor is noted, no uterus cyanosis, clubbing or pedal edema present, multiple subcentimetric lymph nodes palpable in the bilateral cervical region. Head to toe examination, there is no dysmorphic faces. Head shows frontal bursing is there. Anterior fontanelle is almost closed, admits only tip of the finger. Eyes, ears, and nose normal. Abdomen appears distended with everted umbilicus. A small hyperpigmented macula of size approximately 0.5 centimeters present in the posterior aspect of the left thigh. Um, Rest of spine, genital, and limbs are normal. Pulse polyimmunization is present in his little finger. Anthropometry, the weight.
We'll see the patient and
Within limits, we won't make him cry, but within limits, just not talking about as usual, whether his growth is all right, whether his nutrition is all right, whether he's sick or not sick, is he comfortable, is he chronically sick, acutely sick, all those things we can make out. So let somebody else talk. Come on. Please present him, so we'll ask her whether our impressions are right or wrong, right? Anyone, come on.
Are you comfortable? Appropriately modified.
When you are looking at growth, what are the things you are looking at? One is the length or height, and second, muscle mass and fat and all that. So look at both the things separately, individually, and say,
Muscle mass is okay, then recently not very good, but fair. But I can see protein deficiency. Hairs are very small. Okay, and maybe cheeks are also little protuberant. Mashup also. Then you see nutrition is normal. Look at the hair. Hair are stars. You know the signs of protein deficiency, amino acid deficiency. Agree?
Usually pluck out and scars could be from beginning.
could be from beginning, so
Yeah,
ask.
and it's not big, it's quite colored. Okay. So this is not protein deficiency at all, and therefore you're right. Okay. But I can see some lymph nodes here. Hmm? There is a lymph node nothing. Nothing. And it's a posterior survival. And the scalp looks clean. The draining area. Okay, is quite all right. No,
Ear,
Yeah.
no, she's saying ear
Yeah.
infection can cause.
So, ear infection doesn't cause a posterior survival. Okay, it's not a draining area. The point is, I just wanted to bring out to your thing, it's a possibly not a significant, even if the lymph node is not significant, so we'll leave it at that. Okay. And now,
देखो अभी घुमा के देखो होता है क्या ऐसा दिखा आपके बोर्ड में वेट कॉफ
I don't know why you have to call, for him to ask this question. Okay, but in exam you never know what is the, okay, wet cough. Related to this illness? No, you know, it's related. It has been cardiac failure. Even anyone, cardiac failure is lung problem. So years of cardiac failure. Only an infection. No? Because cardiac failure is a wet cough. Of course it's wet cough. Okay. Of course we call it cardiac asthma.
so should be accompanied with tachypnea, respiratory distress.
You don't feel closely. Okay, my question is, if it's anemia, what type of cardiac failure is it? Left or right? When it's right, and the right has no cause. The left has a cause. Okay. So this is how you make it. What do you want? Okay. I think we here or because he's crying, but ले जाओ क्योंकि होता है ना तकलीफ हो जाएगी उसको अब ले जाओ. Thank you. So we are fine.
Anthropometry, weight was 7.6 kg, which is between -2 to -3 standard deviation, and length is 71.4 centimeter, which is between -2 to -3 standard deviation. Head circumference 45 centimeter, between -1 to 0 standard deviation. Mid upper arm circumference 12.5, between -2 to -1 standard deviation. Weight for height was less than -3 standard deviation. Impression SAM with stunting, severe acute malnutrition with stunting. Um, Abdominal examination, inspection, abdominal distension is seen. Planks are full with left side more than the right side. All the quadrants move equally with respiration. Dilated veins are seen over the abdomen, the anterior and the lateral aspect. Umbilicus appears everted. Skin over the abdomen appears normal. No scars and sinuses seen. Hernial orifices are free. External genitalia is normal. Palpation, inspected findings are confirmed. Superficial palpation, no local tenderness or rise in temperature present. Deep palpation, liver is palpable 3 centimeters below the right costal margin in the mid-clavicular line, which is firm in consistency. Surface of the liver is smooth with rounded margins. Borders are well felt and regular, non-tender, and left lobe of liver is not palpable. And spleen is palpable almost 12 centimeters below the left costal margin, extending towards the umbilicus. Splenic notch is felt. According to Hackett's grading system, it's grade 3 splenomegaly, firm in consistency, surface is smooth and non-tender. There is no generalized tenderness or rigidity present on deep palpation of abdomen. On percussion, liver span is found to be 10 centimeter. Resonant note is heard. Auscultation, bowel sounds are present. My final impression, a 1-year-old male child brought with complaints of chronic, gradually progressive generalized abdominal distension and a palpable mass in the left side of the abdomen with anemia, and clinical examination suggested of pallor with Hackett's grade 3 splenomegaly with hepatomegaly, and cervical lymphadenopathy is a case of anemia with splenohepatomegaly under evaluation in a severe acute malnourished child and partially immunized child. Differential diagnosis, hemolytic anemia with extramedullary hematopoiesis, infiltrative disorders of the bone marrow, and storage disorders. Investigations done.
Look at that.
So between the two EDs, how do you justify each one? So on what the ground do you justify the first one?
My diagnosis to the chronic liver disease. Span is 10 centimeters. Liver is formed. 10 centimeters is enlarged liver. Okay, 1-year-old. 10 is certainly high. It's form liver. So form liver is also abnormal. Okay. So you have a chronic liver disease. That is certain. And then you have a spleen. So support hypertension. There is malnutrition, who's in favor of a chronic liver disease. There is no jaundice, does not matter, chronic liver disease. Okay. Why not bring in a chronic liver disease first? There is hemolytic anemia. There is no hemolytic anemia. There is no faces. No. So, have you seen a thalassemia which is malnourished? No, Sino hospital has many thalassemia. Okay. So you must answer this. Have you seen thalassemia with malnutrition? You have not seen, right? So why is thalassemia not malnourished? The rest of the population is malnourished. And in that rest of the malnourished population, to get thalassemia, they should good nutrition. You're finding the right. What you have seen is right. The thalassemia measure is under medical supervision right from early time, and is getting repeated. Now, he gets a PAC-shell, so he's not getting protein, etc. But he's under medical supervision, so it's not that he cannot be. But suppose you're following a thalassemia who is not malnourished, and now he is not malnourished.
What can happen?
What can you have? The first thalassemia was malnourished over feeding for socioeconomic group and also thalassemia. That's a combination. Okay. And then the doctor has not been advising properly. Okay, all that. But suppose I have 3, 4, 5, 6 years I am following with transfusion and now suddenly he's going down.
Transfusion, acquired infection.
And what infection? So HIV, chronic hepatitis, so all that. Okay. So why not chronic liver disease in this time?
No ascites. She's saying no ascites.
No ascites is still chronic liver disease. Okay, but she said dilated veins, right? I forgot to put that dilated veins under my dilated veins, mesomegaly, hepatomegaly, hepatomegaly, 100% chronic liver disease.
So they should be enlarged and tortuous for them to be abnormal.
Okay, so they may be visible but not inverse. We did not see all that. Okay, but can the hemolytic anemia have a form liver and a blood liver? Yes, why not? Isn't it? It will not be a chronic liver disease. Okay. And they've got this child, 1 year old, just last 3 months, the whole story coming up. It's too early to get malnutrition. So malnutrition is all nutritional. And she gave a good nutritional history. Mostly breastfeeding and about rice flour, etc. So this is a nutritional problem and that adds to the liver. Can malnutrition give rise to hepatomegaly? So you may have a fatty liver. Okay. So add to all that. So it's not a chronic liver disease. What kind of hemolytic anemia? There is no extramedullary hematopoiesis, right? No abnormal faces. So what is this extramedullary hematopoiesis?
He's saying liver spleen is the extramedullary.
Okay, but that is non-specific. Bone marrow is not showing anything. Okay. So can you still consider hemolytic anemia when there is no faces at all?
Yeah, cases can come up later, so we'll wait.
And the second is he has still time to develop like that, right? So we'll leave there. What infiltrative disorders? That means some storage of malignancy, both are infiltrated. Would you consider them?
So now with this bleeding history, CML is also possible.
So we'll keep that on, isn't it? But less likely she has put down priority.
The CBC picture of the child. Total cancer 42,200 with a lymphocyte predominance. Observed lymphocyte count 18,900 and neutrophils are 12,100. And hemoglobin was 4, hematocrit of 16.6, and RBC indices were MCV is 57, which is low, MCH is 13.7, MCHC is 24.1, and platelets are 6,42,000. RDW is 28.3, and Menser index was 19. Sir. Peripheral smear was done. RBCs were microcytic and hypochromic. Anisocytosis, polychromasia, and normoblastic RBCs were seen. Occasional target cells and teardrop cells were present. Total WBCs, activated lymphocytes were seen. Platelets are adequate. Reticulocytes was 6% and corrected reticulocyte count was 2.1%. This LFTs were OT was 34 and PT was 18. Total protein was 7.5 with albumin of 3.9 and blood urine nitrogen 4 and serum creatinine was 0.4. And his HPLC was sent, but the report was awaited, sir, actually.
Okay. So what do you think? CBC suggests you of what?
Leukocytosis is there. And
So leukocytosis is due to what? What is
peripheral
contributing to it?
peripheral smear is suggestive of normoblastic RBCs, which can be counted by the Coulter under total
Correct.
leukocytes.
So it is being contributed by normoblasts, right?
Mm.
So this CBC suggests you of which hemolytic anemia?
Extravascular
Thalassemia.
thalassemia.
Suggests you of thalassemia. Go on.
Mm.
So what will be the RDW in thalassemia? Increased. So you said increased is iron deficiency. So then why thalassemia actually increased? Very high. Why? All different sizes of cells, so very high. So normal is talcate, some increases iron deficiency or any deficiency, and tremendous increases adenine.
But you still will worry about liver, right? After hemolytic anemia will have a liver affection, iron is getting accumulated. You may have an iron deposition. Okay, if you ignore it, you will commit cirrhosis. So just now he has no chronic liver disease, I agree. But iron must have started depositing. Okay. And I think I would rather do a study for iron deposition. Which will look,
When do you start monitoring for iron overload?
of course,
After 10 transfusions.
and more than that, depending on the ultimately biochemical thing, but yes, several transfusions.
So you go by creatinine levels or you go by MRI
So do you think,
estimation of liver iron.
you think transfusion is the cause of iron deposition? I thought the disease is the cause. After in immortal cells, the cells are getting destroyed, no? So is that the cause of iron deposition or is the transfusion? You are doing harm by giving a transfusion. So it's related to transfusion because you're including some more iron through that transfusion. And only when you have given multiple transfusions, okay, that the serum iron and the biochemistry will start moving up, and then you might need an iron chelation, right? Good. Well done. So this worked well today.
She said it went well.
Okay.
Oh.
Now see, we must thank Hemant and Archana for doing all this. And this is a pilot study, okay, and it's going only to a few people. of able to come but not in time. I have not learned that etiology as yet. Either you can't come because you are busy, or you can come. Okay. And late Dr. Merchant, who was the chief at Wadia, always said that if you are busy, then you are always on time because you know how to manage time. So every time somebody came late, said, don't say you are busy. Busy people always come on time. So even if I'm not busy, I come on time.
ये सब चीजों को चार्ज
Let me
करके लाना
understand
पड़ता
that
है
even not busy can come on. So I think spread a word. Okay, some of your seniors take a note of this. Then only we will let everybody in the country know this is possible. They have taken a lot of efforts to do that. Okay, I understand nothing about that technology. Okay, but
I could do it today.
yeah.
Father.
So, but we will have to learn after
Yeah.
learning continues in medicine.
Yeah.
So we will have to learn. So would seniors take a charge of this? We will have another pilot for a while, but
Yeah.
let 2 to 5
Maybe
come
by
in.
New Year we can.
Yeah,
We should be able
and
to.
it's not far off.
15
Okay,
days.
we have one more Thursday to come. Thereafter, the Thursday is the Christmas day, so we may not meet.
No,
And
Thursday is not a
25th.
Christmas day. 26th.
26th, is it?
Yes.
Okay, so we will have still 2 more.
2 more
And
Thursdays.
then
We
by
can
January
announce.
we must. So shall we announce that from January we have this kind of a thing? What do you think? Those who say yes will be highly responsive. Okay. Otherwise we will face the wrath of people. Okay. Thank you.
Thank you. Both of you presented well.
Yeah. Both of them did good job.
Thank you, Dr. Amdekar. Thank you, sir. Thank you, Rajesh. Thank you, Archana. Thank you, Pallavi. I think we can close.
Yes, ma'am.